Hello, everyone. Well, you know what they say, we save the best for last. So thanks for everybody for sticking around. We're in CHIP Part 10, Interventions and Beyond. I'm not Ajay Kurtne, although I have much more hair. So you can quote me on that. But I'm here with my moderator, Bill Fearon. We've got a really action-packed hour and a half. And so I think we're just going to jump right in. And I understand there's not a robotic talk. Is that right, Bill?
Pharmacology.
Pharmacology. Okay. We're going to start with pharmacology.
Hey, everyone.
Okay, Jennifer.
Take it away.
Yes. Thanks, everyone. So I'm going to keep everybody awake with a pharmacotherapy talk. And we're going to specifically talk about some of the innovations and some of the new pharmacotherapy that's currently being studied right now and really focus on that. So let's go forward. Here's my disclosure. So I'm going to focus a little bit about my role on the Cameo registry and Cangrelor, the SOS AMI trial that's currently enrolling internationally and here in the U.S., as well as another trial that's coming down the pipeline for adjunctive therapy during PCI through Novo Nordisk. So factors to consider when deciding optimal antithrombotic therapies. To talk about what's coming, I think we need to know and sort of set the landscape. So anytime you're thinking about adjunctive strategies in PCI, you've really got to think about what type of patient you're dealing with, whether it's an urgent presentation, whether the patient has high-risk features, whether the patient themselves is high risk. So are they older? Do they have low BMI? Do they have renal dysfunction? We know that that's critical to understand those various factors to determine what your strategies are going to be. And then this is something I really keep focus in on is P2Y12 inhibition. So we all know the oral inhibitors very, very well, but I think sometimes don't always understand when we're bringing patients to the lab. If you have a lack of upstream loading or you don't have adequate time to get P2Y12 inhibition, what sort of downstream consequences that could mean. And we know from our NCDR data recently that there's a big variation in how labs use these other adjunctive therapies like Cangrelor. Obviously, Cangrelor can be more expensive than some of the other therapies like a GPI, so that may limit to some degree what certain labs do. But then GPIs, we also know, can build up in patients with renal dysfunction, older patients. And so there's a lot of really complex considerations to make when you're thinking about what specifically to give as an adjunctive therapy. I always make sure my fellows know this when they're coming to the lab. When you're giving somebody ticagrelor or prasugrel on the table, they're laying on the table, they take it, you don't crush it. You're talking about a half an hour until you have adequate platelet inhibition, okay? With clopidogrel, we bring that stable patient that had the stress test that was abnormal, you give them clopidogrel on the table, you're really talking about an hour and a half to 2 hours until you have adequate platelet inhibition, and that can be pretty critical. We know that through the Mojito trial, obviously, crushed ticagrelor cuts down about 15 minutes in terms of adequate platelet inhibition. But we also, and we're studying this more and more in some current work that we're doing with Cangrelor, just the kind of impact that morphine and other opiates can have on platelet inhibition. So we have a lot of data about morphine, not so much about fentanyl. So a lot of labs use fentanyl and Versed. We don't have as much data about what the impact of fentanyl is and can be on platelet inhibition in your oral therapies. So this is some work, and this is from some colleagues at MedStar, Washington MedStar, and this was all retrospective observational data but was recently published, where they looked at all of their all-comers that got PCI, and they looked at GPIs versus Cangrelor. And you can see here, and obviously very confounded, right? Even if you adjust for a lot of the different variables here, there's still residual confounding. But you can see in terms of TVR and myocardial infarction, Cangrelor did a little bit better here. And certainly we're starting to look at some of that data within our own registry to sort of parse out what we should be doing because it's so variable by local institution what's being done around the United States. This is one of my favorite sub-studies of Champion Phoenix from Greg Stone. This looked at patients that had really high risk lesion complexity, okay? And so they measured or they gave patients various risk factors, whether it was complex, left main, bifurcation, heavily calcified. And you can see across the board, whether it was stable ischemic heart disease or ACS, that cangrelor versus clopidogrel loading of 600 did better in terms of 48-hour MACE. But we know that there's some issues with cangrelor as well. And so within our registry, and this is 12 sites throughout the United States, about 4,000 patients have been enrolled to date. This is on top of really contemporary P2Y12 inhibition. We've seen some things that are a little concerning. So we all know that with cangrelor, you could overlap it with ticagrelor. We know with the other ones, you have to immediately give it afterwards. That can be problematic because anytime you're having to give a medication outside of the cath lab, you have a little bit less control about when that's given and how it's loaded subsequently. So this was some of our early data, and I think many people that were on this committee, the steering committee, did not believe it because the data was so dramatic in terms of clopidogrel and prasugrel, patients waiting hours and hours and hours to get loaded, to get their oral P2Y12 transition throughout the US, and this is 12 large sites that you guys would all know. 27% of patients were administered it correctly, cangrelor correctly, according to the FDA package labeling. So a little concerning from that perspective, given you know that the cangrelor half-life is about 4 minutes, and you're waiting hours and hours to get a loading dose, that can be concerning. This is some other work we did. This was inspired by Dominic Angiolillo's SWAP-5 study. And then his newer work that's going to be presented at ESC on prasugrel. So patients that are given upstream loading of ticagrelor or prasugrel or clopidogrel, how many times do you take care of patients that got upstream loading like 15 minutes beforehand? They come to your lab. You're not quite sure if they have adequate platelet inhibition and what to do at that point. So we looked at, well, within a real-world study population of 4,000 patients, is the bleeding a lot worse if you go ahead and give cangrelor if you see high-risk features? And we found on top of ticagrelor that there wasn't increased bleeding in the STEMI, non-STEMI patients, or even if they had gotten it just an hour before. So a lot of controversy, I think, that's going on with heparin versus bivalirudin. We thought the bivalirudin story was really over. And then BRIGHT-4 came out last year and I think sort of opened up some conversations about whether bivalirudin has a resurgent or another need to be used in STEMI population in particular. There was obviously some significant trends towards decreased mortality and decreased bleeding with bivalirudin. It was in a primarily Chinese-based population. Really yet to be seen whether it will change anywhere in the guidelines, in the European guidelines. Bivalirudin had been put down to a 2A indication. So I think a lot of labs still haven't taken it back up again, but we'll see if in fact bivalirudin becomes more popular in the coming years. You know, given comparison to heparin, which is pennies, a prolonged infusion of bivalirudin is still $150 to $200. So I think that will still have some impact on whether it resurges in use. Lastly, I'll talk about the Alpheus trial. You know, I think with this stable ischemic heart disease, we've seen in our NCDR registry data more recently that we've looked at that there's really been a decrease in use of any sort of higher potent antiplatelet therapy in patients with stable ischemic heart disease. That has increasingly dropped even further over sort of contemporary time periods of the last couple of years. I'll just remind you that compared to clopidogrel and stable ischemic heart disease, really no ischemic benefit and some increased risk of minor bleeding seen with ticagrelor versus clopidogrel. I think some really interesting agents in the pipeline, and so maybe I'll talk about these just a little bit. Selatogrel is, some people call it the blow dart Plavix, the EpiPen for the heart attack. It's being currently studied within the SOS-AMI trial. This is a large international trial. The DCRI is the coordinating center for SOS-AMI. And so patients are treated with contemporary P2Y12 inhibition, ticagrelor, aspirin, prasugrel, aspirin. And then when they have recurrent chest pain, they give themselves a subcutaneous injection of selatogrel. It is supposed to essentially sort of work like subcutaneous cangrelor, I have cathed 2 of these patients, STEMI presentations, recurrent STEMI, that have taken selatogrel. And one of the interesting things that we're noticing is oftentimes the ST elevations will resolve after the selatogrel injection, and when you get them to the lab, there seems to be some recanalization of the clot burden. So I'm excited to see what that does. Obviously, having a patient and having them trained to take a subcutaneous injection, never super popular, but I think it could be an agent coming down the stream. The other one I want to call your attention to is ziltivekimab. So this is an IL-6 inhibitor. And we've all discussed the inflammatory pathway through the years. Colchicine, you may have seen the ASCVD guidelines just came out. It's now recommended as a potential agent. So we're really excited, particularly within the PAD space for colchicine. Cantos obviously studied another IL-1 inhibitor. There wasn't much success within that trial, but Novo is now supporting and sponsoring a trial that will be coming out a little bit later this year. It will be international here within the US of ziltivekimab. It's an IL-6 inhibitor, and we're going to give it either just before PCI or just after. And it's thought that really the inflammatory milieu that may be present in AMI, that this could really help to decrease that milieu and ultimately have better MACE outcomes. So in conclusion, planning and careful consideration of the patient's ischemic and bleeding risk profile is really necessary. Thinking about bridging, so I really want to call your attention, if you don't think you have adequate oral P2Y12 inhibition, thinking about agents like Cangrelor, potentially GPIs. We are also studying Cangrelor right now within cardiogenic shock, and I'm really excited to see what that data is going to show. Any pharmacologic strategy, though, in complex PCI can fail if bleeding avoidance strategies are not considered. So you really have to consider that background, those background strategies as well. All right.
Great, thanks, Jennifer. That was terrific. Maybe we can start off, and I just wondered if you could kind of outline in your ACS patients, either non-ST elevation or STEMI, what your approach is for upstream treatment with oral P2Y12, and then how you incorporate Cangrelor, like which patients you might use it or might not in.
Yeah, I think that's something that's really tough, and it's, everyone has a different perspective on this. So particularly with those STEMI patients that may be presenting to an outside tertiary, or not a tertiary care center, but a community hospital, and it may be 30 or 45 minutes before they're going to get to my center, I tell them to give ticagrelor, to give a loading dose of clopidogrel based on what they have on their formulary. If they're showing up to your ED and they're going to come upstairs within 5-10 minutes, I'm not sure that there's benefit at that point. And our data with concomitant ticagrelor or Cangrelor does make me feel a little bit better about the bleeding risk. However, if it's a 5 or 10 minute wait, I say oftentimes just hold. We'll figure out the thrombus burden upstairs and start an IV infusion at that point.
I have a question, a great presentation about Lovenox or enoxaparin compared to heparin for NSTEMI. There's a lot of push from administration, emergency room, and the hospital because of the shortage in the nurses, not to check PTT, and we did our own data. We are only 27% of NSTEMI are therapeutic on IV heparin. So we are switching to enoxaparin. What's your take on the use of it?
I think whatever you can give and give it well is the most important. I think the only thing I worry about is we have outside referral centers that are then sending us in non-STEMIs to do PCI. Switching between heparin and enoxaparin, that makes me a little nervous, but I do agree, you oftentimes see these PTTs that are in the 30 to 40 range all weekend, and you've essentially not given drug. So I would say whatever your institution can do and do well. And I think that that's the same with Cangrelor. We've seen just, especially with bridge infusions and bridge dosing now, seen the bridge dosing all over the place in terms of what people are comfortable on different units. So I think, in terms of these sort of antithrombotic, antiplatelets, whatever you do and can do well and do algorithmically is most important.
Jennifer, great talk. I have a quick question regarding heparin and bivalirudin. I think one of the major limitations of using bivalirudin is the cost. And so are there any measures being taken to get the cost down?
Well, so as you may know, the cost is much increased from what it was in the past. And I think when we think about, so I looked at what, according to Bright 4, the cost of bivalirudin and the continuous infusion would be at my institution, it would be about $200. And I think in the setting of then all the other things we're doing, balloon pumps, Impella, things like that, that certainly seems quite low. But when you're comparing it across a vast number of patients to heparin infusion, that's pennies, I would say that I doubt that U.S. practices will change. And I'm not sure, I am still a little skeptical because the data on heparin bivalirudin has been so mixed. And certainly, I think that there are certain limitations of that trial that I alluded to some of them. So I suspect we will stay as a heparin-dominant nation in particular, but I do think that there are obvious uses for bivalirudin in certain patients. But I think widespread, I'm not sure that I necessarily see the benefit.
Question from the audience?
Yeah, I have a question. Wonderful talk. Star, about your opinion about giving crushed Brilinta and prasugrel in the ER or in the emergency room. The ER physicians are pretty reluctant to do that. And so every time I have to tell them, actually, can we do that as a protocol, giving crushed Brilinta and or prasugrel in the emergency room or in the ambulance? Because I think it's, as you said, the absorption is much better. If you just give it orally, it takes about an hour and a half. And particularly patients going for acute MI, I think it's much useful. And I've also seen the bleeding complications with giving the crushed Brilinta. I don't use crushed prasugrel. I don't know whether it's approved or not, but it's much less. Previously, you used to use 2B3As, and bleeding complications used to be high. So what do you think about that?
Yeah, so we do have it as a part of our algorithm. We had, I think the consequences of not having adequate platelet inhibition much greater, I think, than the consequences of, potentially some additional bleeding with crushed ticagrelor, or in particular, when you start to think about the concomitant agents that you'll use as a result of not having adequate platelet inhibition. I oftentimes see the practice, and I know these practices are widespread because we've just pulled the data from CathPCI. GPI use in the United States is still extraordinarily high, in particular this concept of giving an oral P2Y12 inhibitor, doing the 2 boluses of eptifibatide, often in cases where you don't know the renal dysfunction or the degree of it, and that's going to hang on for hours. So I would just say it's a complex thing. We have it as a part of our algorithm to do. There's not a lot of data on crushed prasugrel, so we don't have that as a part of our algorithm. But I would just say think about when there's bleeding concerns brought up, then bring up the bleeding concerns that exist with 2 boluses of eptifibatide in a lot of our patients. So.
One more question from the audience? Side.
Great talk, Jennifer. I have a question. Do you have any experience with using Cangrelor more than the approved 2 hours for some reason in some patients?
For using it for 2, you said 2 hours?
More than 2 hours.
Oh, yes. So we, so as you may know, and I'll step back, so Cangrelor bolus of 30 micrograms, the typical infusion of 4 micrograms for 2 hours of the duration of the PCI. And then even though it's off-label, the 0.75 bridge dose, we use it all the time. And certainly when we queried the 4,000 patients that we've enrolled who are Cangrelor users in the United States, about 30% of those patients will get an infusion greater than 4 hours, okay? And some of those are continuing at PCI doses, some of those are continuing at a bridge dose. So there's widespread practices around what's being done currently. I think particularly in the cardiogenic shock, cardiac arrest patients, the bridge dosing and the prolonged infusions, it's probably something we should be thinking about. I do think that there's a real lack of gut absorption in those patients that are maybe intubated, they're in shock, they have extreme lactic acid doses, their gut is not perfusing in an appropriate way. So that is particularly when we're seeing it, when there's MCS being utilized, when the patient's intubated on ventilatory support. we're seeing those prolonged infusions. We're currently looking at the outcomes of those patients compared to some other strategies, and hopefully we'll be able to present that a little bit later this year. But I think that the worrisome part of me is just the amount of variability in dosing of cangrelor in those patients and what that could mean for bleeding risk.
Thank you.
Great. Thank you, Jennifer. That was terrific. I think we'll move on. Now we have Salman Alana, who's going to speak about coronary CTA for PCI.
Good morning, everyone. Thank you so much for having me. It's been a great conference. In the next few minutes, I'll talk about the use of coronary CT in PCI planning. I'll present some preliminary data, but stick to the algorithm of this conference, which has been case-based. So I think that would be the most learning aspect. These are my disclosures. So we know the coronary CT has increased in utilization over the past few years. It's utilized in the diagnosis of coronary artery disease. With the ischemia trial, there's also been prognosis of coronary artery disease with the use of CT. And it can actually predict coronary artery disease with a very high negative predictive value. With the softwares available, it can also assess plaque composition. And then the CT-FFR has been very, very useful, not only assessing the anatomy, but also assessing the physiology of coronary artery disease. And this is a recent feature that has been added with the CT FFR, which is a CT-FFR planner. We have seen similar kind of softwares in our cath labs. But you can see that with these, you can actually predict the lesion, physiologically assess the lesion, and also put in a virtual stent with an accurate length of the stent and predict a post-PCI FFR using CT even before you actually go in the procedure. For the most important utility of CTA is in planning complex coronary intervention, especially CTOs. It can assess proximal cap ambiguity, the vessel course, which has been really, really ambiguous, especially in many cases that we do. Calcification, it's actually much, much better. The sensitivity of CT in assessing calcification is much better when compared to coronary angiography. It can assess the origin of the bypass grafts and the course of the bypass grafts. Identification of the distal graft. The main problem in CT is the collaterals, assessment of collaterals. The special resolution is about 0.6 millimeter, even with the best of CT scanners. And so it is not really good in assessing collaterals or vessels less than 2 millimeters. Over the past few years, this is the data from the Progress CTO registry, and especially for CTOs, the use of coronary CT for procedure planning has increased with a total overall use about 5.3%, but has slowly been rising. And we are aware of the CT-CTO trial in which 400 patients were randomized to CT-guided CTO-PCI versus angiographically guided CTO-PCI. And you can see that the patients who had a coronary CTA-guided PCI had a higher technical success rates, as compared 94% as compared to 84%, with no significant difference in major adverse cardiovascular events. And this is a great example of a proximal cap ambiguity. You can see that the vessel, this is a right coronary artery. The right coronary artery is occluded in the proximal segment. There's a branch in the proximal that's coming off. And this is here where the distal cap is, a long length. And there's a huge area of space, dead space. We don't know where the vessel goes. Is it going that way, this way? Is it tortuous? And you do a CT scan, it really outlines the course of the vessel. It is a very tortuous vessel with significant calcification. And if you attempt, for example, antegrade wire escalation in this situation and the wire is going down, you know that you are probably outside the vessel architecture. So let's see some cases in which CT has actually really affected the procedure planning or the procedure itself. This is a patient who is a 69-year-old male who presented with angina, and he had a coronary angiogram that was performed. The target vessel is right coronary artery. This is the proximal cap, an ambiguous proximal cap. You can see multiple ipsilateral bridging collaterals that fill this area of the right coronary artery in the mid-segment, and there's another occlusion in the distal right coronary artery. The bifurcation appears to be a distal cap. So very high-risk features, proximal ambiguous cap, a lot of ipsilateral collaterals, long occlusion length, bifurcation, distal cap at the bifurcation. This patient, we did a CT scan, and you can see quite a lot of features that actually know that not only angiographically, even with CT, you can identify a lot of factors that would be challenging to negotiate. You can see that the vessel proximally is tortuous. There is calcification at the proximal cap, which really is identified very well with the CT. And then you have an occlusion here, and then another occlusion right at the RV marginal branch. So the other thing also is the course of the vessel appears to be turning. It's in this situation, unfortunately, CT was not really able to define the actual course of the vessel, but you can get an idea that it's actually going more towards the right side in this view. So this is 3D rendered imaging, and shows very similar. There's a calcification at this cap, and then area which is filled by collaterals, and then whole area of another occlusion. The angio simulated, so you can actually treat this. You use different views on the CT scan. These are angio simulated images, and again, it sees the calcium. It's not projecting really well, but you can actually see the calcium really well here at the proximal cap, tortuosity of the vessel. And here you can see the distal cap. You have a posterior lateral and a PDA coming in. So a lot of features that you can see on the CT scan even before you go, and you know that this is probably going to be a dissection reentry, either retrograde or likely a retrograde case. So in this situation, we tried retrograde. We went retrograde as per the hybrid algorithm and the global CTO crossing algorithm. We're not able to cross we're not able to serve the septal. However, we were able to take this epicardial from the left circumflex artery. You can see the epicardial. We are in the epicardial, able to get the Sion black wire with a microcatheter at the distal cap over here. And then we went antegrade, and of course, with this proximal cap ambiguity, in this situation, we did balloon-assisted subintimal entry, and you can see how the knuckle goes in, so tortuous. If you try to attempt wire escalation in this kind of scenario, and if it's going straight, you know that you are outside the vessel architecture. This case was completed using reverse cart and a good angiographic result. Another case of a 60-year-old male who presented with NSTEMI and had a coronary angiogram. I'll just skip it for the time's sake, but the important thing was the culprit was the lesion in the SVG graft. And patient had a PCI, just balloon angioplasty of the graft, was brought back for the CTO of the right coronary artery. And you can see a lot of features that tell you exactly what to expect. A very significantly calcified proximal cap, which is going to be hard to negotiate. We know that up front. There's a large, not much calcification in the mid-segment, which is encouraging. There's a long area of occlusion, which is in stent. And then the graft, and you can see that the angle, because there was a kink at where the anastomosis was done, but the angle from the graft coming retrograde to the PDA is favorable. However, there is calcification at the distal cap, and the distal cap is at the bifurcation. So this is a retrograde approach. We went retrograde through the vein graft, and then, however, because of the calcification of the distal cap that we know, we even tried with the Gladius Mongo, took a small branch, and we were outside the vessel architecture, and you see a large perforation. Went retrograde with a papyrus stent, sealed off the perforation. However, now we know if we go antegrade, we've closed the doors to the retrograde approach, we go antegrade, and there is a very, very large calcification, calcified proximal cap. And so we went up front, a starter wire did not, we tried a few minutes, did not work. We knew it's likely not going to work. Quickly switched to Carlino, get subintimal, and we're able to get the knuckle down very quickly. and we're able to puncture the papyrus stent from the extraplaque space using a Hornet 14 into the posterior lateral, wired the PDA and snared the PDA. I've not shown this for the time's sake, but did bifurcation stenting and got a good angiographic result. 78-year-old male who presents with medical refractory angina. You can see that there is a long area of stent from the LAD into the diagonal artery. And you can see that, especially in this view, you have a retrograde filling of this LAD. And it goes way back somewhere in this segment. The proximal cap is ambiguous, the distal cap is ambiguous, large, the occlusion length may be small, but you know that this is going to be challenging too. In this situation, we went retrograde with the wire microcatheter. However, we're not able to enter back into that stented segment of the LAD. We tried really hard, a Stato, we tried CART, a reverse CART. We try to get a retrograde in the subintimal plane, but really not able to get into the vessel. And we did a CT scan, and this was why. So in this case, we know this is the LAD that is really jailed by the LAD to the diagonal stent. And there's either 2 layers of stent that you can see or calcification with the stent. So it was extremely hard to puncture back into the LAD. And you can see that extensively calcified or double layer of stents. And so this was, but this patient also had a prior bypass, and lima was known to be atretic. So in this CT scan helped us because we could see the proximal segment of the lima that was patent. So this, of course, we're going to go in again. If we try to do the same thing, may not work. Let's change the strategy. And in this situation, we actually engaged the lima. We went in. And you can see that there is something, it's filling right there. The lima is anastomosed to the diagonal, and there is filling of something that's going to possibly the LAD, which is highlighted here. We're able to get through the lima into the LAD, through the distal segment of the lima. However, we're not able to get into the LAD. We then went retrograde, and then in the distal segment of the lima, did a reverse CART in the lima, and then were able to externalize, and then rather than opening up the native artery, we're able to get lima to the LAD by doing a reverse CART there. Quickly, beware.
I think we're
of the
going
CT
to stop
scan.
there because we're over time. So
Sounds good.
These are fantastic, really fantastic cases. Any questions? Maybe I'll start. So what do you think the impact is going to be of photon counting CT? Our center has moved completely towards photon counting. The advantage is the resolution, being able to see inside stents. Do you think the resolution is going to be capable to assess collateral circulation?
Probably. I mean, we'll see. I mean, the spatial resolution is better, and so if the spatial resolution keeps getting better. Still, the major limitation of the CT is to get any vessel which is less than 2 millimeter. So as the CT gets, we have more slices. The photon emission, I think it may be. I'm not aware of it would help or not in the future.
You see, I think
Ziad, you tell us because you use it, right? So you tell us how it is because some of us have not seen it.
So. The Neotom Alpha is an entirely new technology. Right now, CTs are based on X-ray and light detection. Photon counting has 6 times the resolution. So right now, for example, the guidelines say you can't see inside of a stent that's more than 3.5. You can look inside of a stent that's 2.25. The calcium blooming artifact that happens currently is basically obliterated. So now all that artifact that you see with large segments of calcium not being able to see in the lumen or calculate physiological approaches, that's also significantly improved. So this is a hardware change. It is not a software change. This actually performs CT in an entirely different mechanism. We're fortunate because we are the first center in the Northeast to have a dedicated cardiac CT scanner. It's made such a difference to our patients, we're buying another one. And it's very high throughput. You can do up to 20 scans per day. So the potential for this is multiple. The one thing that I think we've been really pushing on, and for example, I'm talking about this next week at SECT, is right now, CT scanning software is made for the imager. It's not made for the interventionalist. Interventionalists want entirely different pieces of information than the imagers do. We want to know how big, how long of a stent should I place, how much calcium, do I need to do lesion prep? We basically want to perform MLD max guided approach using the CT. The good news is that all the companies are now realizing that they're missing this huge population, and there's a plan to actually integrate CT into the cath lab. Carlos Collette was the first one to do this, where he's integrated the CT scan so that as you move the IIN detector in your room, it'll actually move the CT on the CT planner. And all of the new CT planning softwares will be able to include the ability to measure distal reference, proximal reference vessel length, etc.
Yeah, those are great. Of course, unfortunately, the availability of these technologies are only available at limited centers. One thing, a couple of things that that may be useful in the future. One is the CT fusion, and I don't know if you've had experience with that, and real-time CT with the interventions. And so I think those technologies are still in infancy at most of the centers, unfortunately, and I'm not sure of the availability and applicability of all these approaches in most of the centers in the US.
Yeah, so what someone's talking about is something called DynaCT, where actually they have a CT scan you've done before, then you put the patient on the table, and your II works as a CT scanner and rotates like a gantry around the patient. Then they match the patient's spine on the CT scanner to the spine on your fluoral. And then you can actually have the CT scan up in real time and see where the coronaries are. So for CTO PCI and complex PCI, it can be very, very helpful.
Sam, a quick question, a practical one. So you showed that 5% of operators are doing pre-procedural CTA. What's your percentage, and how do you decide in whom to do it?
Yeah. So overall, I mean, it's not the 5%. Like all the CTOs that are being done, 5% of those have a pre-procedure CT scan that is available. It's not at our center. We do not use it routinely, but still the use is increasing. The cases where we use CT are where, of course, we already have films. There's a proximal ambiguous cap, and I think that's one of the major indications that we use CT, especially if we have previous films available. And the failed cases, especially cases we have failed, we have tried everything, and CT has helped us in assessing what we can do if we have to change our strategies in the future. So overall, I would say for the CTOs, a quarter of those patients, maybe 20% or 25% of the patients who eventually end up getting CTs.
Salman, thank you so much. For the sake of time, we're going to move on. I think CT is really going to continue to be integrated in a big way into our practices, especially in complex PCI. Okay, so a man who needs no introduction with regards to physiology, my co-moderator, Bill Fearon, is going to talk to you about physiology.
Great, thanks, Ziad. So in the next few minutes, I'm going to try to outline 3 key areas where I think the future of coronary physiology is moving. One, the true physiologic guidance of revascularization. The second is the move to the microvasculature. And then lastly, move to wireless physiology. And so when talking about true physiologic guidance of revascularization, what I'm referring to is more universal utilization of physiology. Traditionally, when FFR and IFR were first introduced, it was mainly for ruling out the need for PCI in intermediate lesions. But now we're using it in much more complex patient subsets, and also not just pre-PCI, but throughout the PCI. And so I wanted to highlight one area of complex patients, the FAME3 or multivessel disease patients, where we're deciding about PCI versus CABG. These are the one-year results, and I think many are familiar with the fact that FFR-guided PCI did not meet preset criterion for non-inferiority versus CABG, and so many viewed it as a negative trial. But I think there are some important lessons we can learn from FAME3. In particular, when you compare it to historical control, the Syntax trial, and look at 1-year MACE, you see that both the PCI arm and the CABG arm in FAME3 did better than the CABG arm in Syntax. And the other important thing I think that you notice is that the difference between PCI and CABG has narrowed fairly dramatically compared to historic control. Now, we can also get a little more into the weeds on which patients might benefit more from PCI versus CABG. This is looking at the low syntax score patients, where you see that PCI performs quite favorably compared with the high syntax score. And you can understand this when you look at the role of FFR in these two different groups. In the low syntax score, 30% of the FFRs were negative, and so that's really where you get more of a bang for your buck for measuring physiology, whereas in the high syntax score, much fewer lesions are negative, and so really the FFR plays no role in that setting. Now, when just dividing by syntax score, the low syntax score group is only about 30% of the cases. And in the high syntax, meaning intermediate and high syntax score patients above 22, amongst those 2/3, there's clearly a spectrum. Some do better with PCI and others do worse. And the question is there a way to get some more of those patients into a lower risk group and identify them? And you can do that by calculating what we call the functional syntax score, where after measuring FFR, any vessel that has a negative FFR, you subtract that from the syntax score, and that allows you to identify half of the patients enrolled in the trial who have a low functional syntax score. And these half of the patients have very favorable outcomes when compared with bypass, whereas the high functional syntax score patients have higher event rates. Now, these are all one-year event rates. We just recently reported at EuroPCR the 3-year outcome from FAME3, and the primary endpoint of this 3-year study was just death, MI, and stroke, so no more repeat revascularization, so just hard endpoints. And what you see is that there was no significant difference between PCI and CABG at 3 years when looking at just death, MI, and stroke. And when we look at the components of the composite, importantly, death is essentially identical, and stroke is similar as well. And really, the only difference is with MI, where there was a 2.8% difference. And so I think, you can now have these sort of updated data to explain to your patients, look, at 3 years, you're not going to have any difference in death or stroke. You'll have a 2.8% higher chance of having an MI. And I think that can help inform decisions when we're talking with our patients. Now, another aspect of physiology that's emerging is post-PCI physiology. And in FAME3, we looked at post-PCI FFR, and if you had a higher value, you had a much lower rate of target vessel failure. But I think a key question here is, well, what can we do about this? And can we improve those patients with low post-PCI physiology? And that's being looked at in the DEFINE GPS trial, which is a randomized outcome study looking at IFR-guided PCI versus angio and post-PCI assessment to see if using physiology to help optimize the stent result will lead to better outcomes or not. So stay tuned for those results. And then when I'm talking about more universal application of physiology, we're also learning that we can use it to identify which patients are most likely to benefit from PCI. These are some older data from FAME 1 and 2 looking at quality of life improvement after PCI and breaking it down based on the pre-PCI FFR value. So you'll see that there's 3 sort of categories of FFR values pre-PCI, and the ones with the lowest pre-PCI FFR had the greatest improvement in quality of life, whereas those who just had FFR 0.7 to 0.80 had less improvement. And so it identifies which patients are really going to improve, and it also argues against trials like Orbita, which suggested that PCI just has a sham, placebo effect, because if there's a placebo effect, all 3 of these groups who got PCI would improve in a similar fashion, but you see that there's really a graded fashion. And when you look even more granularly at the delta FFR, so this is the difference between pre and post PCI FFR, or the amount of ischemia that's relieved, you see that the patients with the greatest delta FFR had the greatest improvement in quality of life from baseline to 1 year compared to those with less. And so this concept has led to the development of something called the PPG, or pullback pressure gradient. Carlos Collet and colleagues in Alst have pioneered this index, which is a way of doing a pullback and more quantitatively determining if the disease is diffuse or focal, as opposed to just kind of eyeballing and saying, well, there's a lot of pressure gradient there, I think this is focal. This gives you a quantitative index. And this is being studied. It's been shown to predict post-PCI FFR as well as delta FFR. And it's also being studied in a registry to look at clinical outcomes to see if, again, by doing this assessment, more thorough assessment up front, we can identify which patients will benefit more from revascularization versus others. Quickly, I'll talk a little bit about the move to the microvasculature. We now have capability to easily measure microvascular resistance, IMR, as well as coronary flow reserve, or CFR, readily in the cath lab using the Coroventus system. There are a number of studies. This is just one example showing how assessing the microvasculature can identify patients who have worse outcomes if they have abnormal microvascular function and/or spasm. And then we can use these techniques very readily in the cath lab to stratify our patients to either those with vasospastic angina, microvascular angina, or non-cardiac chest pain, and then guide medical therapy based on what we find. And that was looked at in the CORE-MICA trial, where they randomized patients to this coronary function testing versus standard of care, and showed that those patients who had the testing and then had their medications adjusted to address whatever the findings were had improved quality of life in angina during follow-up. So these studies and others have led to the incorporation of microvascular testing and spasm testing into the guidelines. The most recent guidelines now have a 2A recommendation for doing this in your patients who have non-obstructive coronary disease. And there's also been a lot of enthusiasm throughout the country, the development of this microvascular network. There's some white papers coming out in JACC that are going to hopefully help people create these chest pain centers and establish these programs in their cath lab and other educational opportunities. And so finally, a move to wireless techniques in the cath lab. Many of you probably have some experience with various angiography-derived systems for assessing physiology. There's 3 now that are commercially available. We were involved with CathWorks and FFR Angio and did a study that showed that the comparison with wire-based physiology was quite good, with a very high diagnostic characteristics, accuracy of 92%. The Chinese have published the FAVOR-3 China trial, which looked at QFR versus angio-guided PCI and showed that there was significantly improved outcomes. This is kind of like a redo of FAME-1 trial, but with QFR as opposed to using a pressure wire. And now we've just launched, we've enrolled about 15 patients so far, the All-Rise trial. This is a clinical outcomes study randomizing patients who have an indication for coronary physiology to either FFR angio-guided therapy or wire-based physiology. And the primary endpoint will be 1-year MACE with a non-inferiority design. So stay tuned for those results. And lastly, these angio-derived techniques are now being applied to assessing the microvasculature as well. And so there are methods of measuring microvascular resistance just based on the angiogram without having to put a wire down or give adenosine. And this is an example of a study showing how it can be prognostically helpful in patients who've had successful primary PCI, identifying those with low IMR who have a very good outcome, who you might discharge more quickly, for example. So in conclusion, there's a lot of excitement in coronary physiology. I think it's going to continue to play a big role in our revascularization decisions, and thank you for your attention.
So what you're saying, Bill, is physiology is not dead.
Definitely not dead. Although you're right, there were some studies that got a lot of press and interest that were negative for physiology, and I think that led to people concluding that physiology might be dead. But I think many of those studies were in very sort of extreme scenarios, like measuring FFR in every patient, regardless of if there's a lesion or not. And there's not really a good rationale why that would be helpful, and so it's not surprising that that kind of study is negative.
So as we look into the future, and with the wireless technologies for both physiology and microvascular function, you think the cath lab should invest in getting more microvascular dysfunction wires and equipment and drugs?
Yeah, I mean, I'm a big proponent of this, and others like Tim Henry are as well, that I think there's a huge unmet need for patients with ANOCA, angina with non-obstructive coronary arteries, who still come into the cath lab, have quote-unquote normal coronaries and are told you're fine, it's all in your head, and they end up, I think you quoted, your average patients had 4 prior caths, and they have all this unnecessary testing. And when we can just literally in 10 or 15 minutes do the microvascular assessment, spasm assessment, get at least a better answer as to what's going on, and help. In many cases you can say, in fact, you have normal findings, and you don't need to go to the ER or whatever. You can, we can work up other etiologies, or you can say, yeah, you have microvascular dysfunction or you have a spasm, and really help the patient.
So, Bill, let me ask you a provocative question. It seems like the river is being split in 2 directions, right? So there is that side of the river that's saying do less invasive, do this all by angiography-based techniques, don't invest in wires, don't put things down the coronary. And then there's the other side that says, well, if you really want to look at the microcirculation, you've got to put a wire down, you might have to give it acetylcholine, you need to be more aggressive. What do you say?
Yeah, so it's a great question, and I mean, time will tell. I certainly think that for epicardial assessment, the angio-derived methods, in my opinion, seem to be pretty good. And I think, we need more data. That's why we're doing the All-Rise trial. And, we need to prove whether they are non-inferior or not. My hunch is that they're going to be, just based on all the validation studies, which have shown, for example, they actually correlate better than non-hyperemic pressure ratios. And non-hyperemic pressure ratios are non-inferior. So, you'd think that these will be too. So for that group of patients, I think we will be moving to less and less wire-based methods. But in the microvasculature, that's a little more challenging, and also in spasm too. So I think there's still going to be a role and so I think we need to learn this, and we need to have the capability in our cath labs to do it.
I think Dr. Henry has a question.
Yeah, it's a really excellent talk, Bill. And I think the answer to Zia's question, I think, is both. So I think the place where wireless technique will really help us is post-STEMI. So, because the best correlation with wireless technique is with IMR. And this is a huge problem, because identifying high-risk STEMIs at the time of the PCI, we would be doing much better if we could identify and do something right at the time. And I think you have the ability from the angiogram with CathWorks and QFR to know that the high IMR patients. And then we can randomize those high FFRs. I think that'll be the most. I think for ANOCA or MyoCA, I just don't see it happening, because you need a comprehensive assessment, which includes coronary flow reserve, includes acetylcholine testing, et cetera.
Yeah, no, that's a great point. And I think the other area where these angio techniques will be quite helpful in the STEMI group is for non-culprit assessment. The last thing we all want to do at 3 a.m. after fixing the LAD is to put a wire down the right for that 50% lesion to figure out if it's significant or not. And the last thing the staff want us to do is that too. So I think these angio techniques can really help in that area as well.
I have a quick question. Are there any anatomies that you would not recommend doing angio-FFRs, especially with the false positive results? So what is it? What kind of anatomies we should always go for wire-based rather than angio-FFRs?
Yeah, so it's a great question, and there certainly are cases where the angio techniques don't work well. So osteal lesions are one. I think when you have a lot of vessel overlap and tortuosity and you're unable to separate out the vessels well to get your 3D reconstruction, that's another. So, fortunately, like in the FAST FFR study, the percentage was quite small. I mean, less than 10%. So I think in the vast majority, it's going to be available. But yeah, there are cases where, and we need more data. For example, in some bifurcation lesions, I think we need more data, previous stents, things like that.
Okay, Bill, you get to introduce me.
Oh, yeah, great. So my co-moderator, Ziad Ali, is going to now tell us about the future of intracoronary imaging and tell us the Illumium 4 results, by the way.
Yeah, we're going to break the embargo and just give you the results right here. No, we're not going to do that. Okay. All right, so I'm going to talk to you about the future of intracoronary imaging. I think that dovetails nicely to what Bill was talking about just a few minutes ago. And so these are my disclosures. All right, so what's your flavor? I think we all look towards evidence to help us make decisions, right? So interestingly, imaging and physiology have always been coupled together, right? When they go on conferences, it's the imaging and physiology section. When they fight with each other, it's like brother and sister. Imaging is better, physiology is better. They're always sort of coupled. And finally, we have this randomized control trial, which looked at imaging versus physiology head-to-head and found that at 2 years, there's really no difference whether you use imaging or physiology. So the question is, can you just use either then, right? Doesn't matter. Bill likes to use physiology. I like to use imaging. We don't really need to use both. Well, I think you got to dive into the details a little bit. So if you look, what happens in the imaging group compared to the FFR group? The FFR group, the time for the procedure is shorter. You defer more lesions. The intravascular ultrasound group, you actually end up treating more patients. So there's more stents. The stents are longer, so you cover more plaque. The total number of patients who underwent PCI is slightly higher in the IVUS group, and the total length per patient is pretty much similar. So what does that tell you? And what can we learn from that? What we can learn from that is that they probably protect the patient in slightly different ways. Right? So the imaging, maybe it caps the plaque so you don't get late events. Intracoronary physiology, maybe it defers lesions so you end up not treating lesions that don't need to be treated so you don't get periprocedural MI. And if we can combine those both, maybe we can have a meaningful improvement in endpoints. And so this is where we sort of are, right? So if I'm going to use PCI guidance, I'm going to use OCT or IVUS. And for those of the physiologists, they're going to say, well, I'm going to use one of these 3-letter words and pick based on those, all right? And so this has kind of been the traditional paradigm. But the changing paradigm, which I think has made a big deal, as Bill just mentioned with regards to pressure pullback gradient, also with IFR pullback, defined GPS, the change has been this. So traditionally, we've thought of physiology as 0.78, yes, I should treat, 0.81, no, I'm not going to treat. But now with these new technologies, we're saying, well, wait a minute, it's 0.78, but the PPG is X, so this is diffuse disease, maybe I should leave it. Or I'm doing an IFR pullback and I see 2 discrete step-ups, I need to treat those lesions, but one is worse than the other. So we're learning to use physiology on not only whether to treat, but also how to treat. So these are becoming much more overlapped. And so I would say that one of the big changes has been the ability to do physiology co-registration. Obviously, the SyncVision system was the first system to do that. I think PPG is the next big step in that direction, right? So that as we do a pullback, we can see whether there's a gradient. And Carlos has done a wonderful job to show that the patients who have focal disease do much better in terms of symptomatic relief. Right? So it's not just about ischemia, it's also how your ischemia got there. Bill just showed you that if you have a delta FFR improvement, your ability to improve ischemia, the more focal the lesion, the more likely that is to happen. So focal disease may be better suited towards PCI. So how do we do this on a wider spread scale? Well, what we want to do is we want to integrate the technologies. I want, the house in the Hamptons and I want the apartment in Manhattan. And so how do you do that, right? What you got to do is you got to integrate these technologies. And the way we can integrate these technologies is to allow intravascular imaging to also give us physiology, just like or angio-based system to also give us physiology. CT to also give us physiology. So the future really is here, right? To be able to integrate all of these different modalities. Here's a CT planner by HeartFlow. Here is intraplaque assessment in real time. And so what I want to show you quickly is the ability to actually integrate in real time. So here's the future, I think Bill just talked about this, of invasive physiology. So in a very short period of time, we can actually pick the arteries and create a 3D construction of the heart. This is CathWorks. This takes like a couple minutes. And what do you know? You've learned here not only that this is the ischemic part, but also you can determine the length of the lesion, you can determine the interaction between the bifurcation, you can determine exactly how long your stent needs to be, and very soon you'll be able to determine how big your stent needs to be. So you get the benefits of physiology, you also get the benefits of MLD Max. Or we can go the other way around. This is a brand new technology called OCT Plus, which allows you to get physiology from your OCT pullback. It basically creates a cut every single slice. Obviously, the OCT resolution is very high. As a result, we're able, oh, I'm gonna go back one, sorry. Click that for me. Okay, good. So I didn't want you to miss this because it's important for you guys to watch. Can you play that? Excellent. Okay, so you've got your OCT FFR. You can see what the gradient is across the lesion, and you can also get the OCT FFR to tell you what type of plaque is. So this is everything, right? You've got physiology, you've got plaque assessment, you know exactly where to land your stent so you don't land into a lot of lipid. You want to land in the most normal segment. We can integrate all of these technologies together very quickly. And if IVUS is not your flavor, what we can do is OCT is not your flavor, we can do these same measurements using IVUS. And so we can also do IVUS-based physiology. There's lots of works in this, lots of different companies are working, and you can see it takes just a few seconds. You put your pullback in, the pullback calculates according to the length of your pullback, and you're able to actually look inside the artery and calculate the physiology. So you're going to see us do that here. So we're zooming in so that we are only focusing on the area of the artery that we want to. So I'm basically excluding the guiding catheter, and I'm having the IVUS Plus actually go ahead and integrate the results for me. And so very quickly, again, we're able to see critical pieces of information. We get all of the EL to know how big the artery is. We have the lumen, which will allow us to do stent expansion and measure minimal stent area very quickly. But also, we can get the vessel FFR, right? So everything in one. So for my dollars, if I have to pick one, I'm going to pick the one that allows me to guide the PCI and have the physiology pre and post. So I think this is the future, right? All of these different technologies that we have in our bag, this Swiss Army knife, they all have their advantages and disadvantages. But finally, what if you had a Swiss Army knife that did have everything on it? And so we're getting to that point. So physiology can tell us whether to stent. We can predict our post-stent physiology. We don't have to do hyperemia. The assessment can also allow us anatomically which stent, what type of lesion preparation do I need to do? Did I deploy the stent optimally, and how has flow been restored? So I think this is the future of intracoronary imaging. So basically I'm going to steal all the good things from Bill and put it into imaging. Thanks, guys.
Thank you, Ziad. That was terrific. So I'm going to go right back at you with the similar question that you asked me. I mean, I think clearly we need imaging and physiology, I think. And I think particularly post-PCI across a stent, physiology can normalize before the stent may be optimally expanded. And so we definitely, I think, need imaging to help guide that. But the question is, you know, depending on your threshold for measuring physiology, you know, maybe only 30% are positive, or maybe 50%, depending again, but not all of them. And so, are people going to put a wire and a catheter down where they may not even really necessarily need the catheter, the intravascular imaging component, or will they go for a wireless-based method?
So this goes back to my Swiss Army knife analogy, right? I feel like if you perform intracoronary image, to me, the main value of angio-based FFR is for diagnostic angiography. If you ever do a diagnostic, you're not sure what to do, you don't have to capronize, you don't have to switch guides, you just do it off the diagnostic, you answer your question. But if you're going to do a PCI, right, then intravascular imaging gives you all the benefits of imaging, so perfectly planning your stent, making sure you don't have any post-procedural complications, making sure you do lesion preparation, and now you also get the physiology. So you won't treat the lesions that don't need to be, you leave them alone. And post-PCI, you do a post-PCI pullback, which will give you the max part of MLD max, but also make sure you haven't left residual disease, which we know is present in 25% of cases, and also that we've done the best job we can to get the FFR as high as possible.
Ziad, a fantastic overview, and congratulations for such beautiful work. I wanted to be a bit provocative here, and we're going to be working together. Is the Swiss Army knife analogy that you're using here, where does it fit the coronary CT as not only the diagnostic but also planning tool? Is that going to reduce the use of intravascular imaging? When do you think we're going to get there?
So that's an excellent question, and I think that coronary CT can take a big bite out of this. The only downside to the coronary CT component is you don't have the post, right? You won't get medial dissection, you won't get malapposition, you won't get stent under expansion. And so we know those things predict outcome, and I think we can easily cover it pre. So I think the paradigm here is, you know, pre-PCI coronary CT allows us to assess morphology. We're working with Carlos to determine. You've seen the St. Francis calcium score for OCT. You've seen it for IVUS. We're now going to give you one for CT, right? So tell you when do you need to shockwave or rota based on the CT. And also you can pick all your stent gear beforehand like a TAVR, right? When you go into a TAVR, you already know, I need a 26, I'm putting 1 more milliliter in. We're going to do the same thing with stenting. And the post, you're just going to do like TAVR. So if there's a complication, we're going to have to assess it. Maybe that'll cut imaging down. Maybe you just do a post-PCI angio-based FFR and it's like 0.96 and you're done. But integrating these technologies is what I think really is going to be the holy grail.
Now, one area of future role of intravascular imaging that you didn't really touch on too much, I'm interested in your opinion, is those physiologically negative lesions, FFR 0.82 or IFR 0.91, where you have features of vulnerability on their OCT. What is your prediction regarding, the role of PCI in those settings?
So I don't believe we have enough evidence from any study right now to stent quote-unquote vulnerable plaque. But we can't dismiss the fact that in the large studies, right, LRP, Prospect 2, ischemia, the event rates in the conservative arms start at about 2 or 3 years, which makes sense, right? If you have a lipidic plaque that's moderate, that's not stented, or even it's tight, it takes a certain amount of time for that vulnerability to translate into an infarct. And in my opinion, that is one of the reasons why intravascular imaging seems to give you a more robust long-term benefit. You put in longer stents, you cover more plaque, that plaque can't rupture, you can't get an event. So I think that how we can use that information right now is to cover more plaque, for example. And as you know, the defined GPS protocol and the FAME study are doing opposite things. Defined GPS is saying, cover the whole thing, all the dots, because that's vulnerable. And FAME said, no, wait. We need to be much more judicious in stenting. Just stent the really important parts and leave the rest. And that goes back to flavor. I don't know which one's right. Maybe they're both right. And that's how we can improve the outcomes.
Ziad, just to recap also on Bill's comments, negative FFR or negative physiology, a very vulnerable plaque on imaging. I think this just leads you to be more aggressive with therapy. So I never left a lab without prescribing PCSK9 for these patients if they are on high stats, and I just go PCSK9 straight because this is a vulnerable plaque. If I drop a stent, I think the appropriate use criteria will be after me. But at this point, as you said, there's no studies. But that's a lead to be more aggressive with medical therapy.
We'll get Manos to do the next CVI in Mexico so we can all get our inclisiran for like $800.
All right, great. Thanks, Ziad.
So Bill, if I can take the prerogative, let's cancel the next talk and go straight to Simon Dixon because it's radiation talk, and I think that's the most important, if that's okay.
Okay, terrific. Thank you. Yeah. So next, Simon Dixon is going to talk about radiation protection, state of the art.
I stole the mic, Bill.
Okay, thanks for sticking it out. And towards the end, so Manos, thanks for the invitation. And congratulations on a great meeting. So my task is to talk about radiation protection in the next 5 minutes. And unlike the other speakers, I'm not going to give you a whole bunch of technology and new devices, but I'm going to give you 4 or 5 simple tips today that you can take back to your cath labs on Monday and implement these to significantly reduce your scatter radiation dose without costing a dime. Okay? So when you think about the factors that influence the amount of radiation that we all get in the cath every day, these are the broad groups, right? It's the patient factors, shielding, the X-ray system, and the operator. And I would submit of these factors, the most important is the operator. It really depends on how you drive the cath lab in terms of how much radiation exposure we get. And let me show you why I mean. So here's loading point number 1. Here's 2 cases I did about 5 years ago back to back. A straightforward, relatively type A LAD lesion. And in that case, the Aerokerma dose off the machine was about 400 milligrams. So I patted myself on the back, thought that was pretty darn good. Next case was a retrograde, osteal, CTO, circumflex occlusion, about 3,500 milligrams off the system. So I want to ask you all, so Vlad, which of these 2 cases do you think I got more scatter radiation dose off? CTO. Okay, so instinctively, everyone in the room is going to say, yeah, I used 5 times as much radiation from the cath lab system, so I should have significantly more radiation to me. And in fact, the radiation dose in those cases was 0.6 milligrams in each case. So this was a light bulb moment for me, and I realized that the factors that influence what we get is significant variation, and the angulation makes a huge difference. So these are my radiation doses over the course of about a year, and you can see on the y-axis here is the radiation dose that I got, and on the x-axis is the dose area product. So one of the traditional measures, fluorotime Aerokerma dose area product on the x-axis. And you can see here there's basically no relationship. So in some cases, you can have very small measures of radiation off the machine and have high exposure to us, and conversely, the other way around. So the first message here is you can't rely on measures of X-ray output from the cath lab system to guesstimate how much radiation exposure that we're getting on a case-by-case basis. The only way to do that is to use real-time monitoring. And I would urge you all today, if you don't have a real-time dosimeter in your labs, you need one. I recently bought systems for every single fellow in my cath lab has a real-time dosimeter. Every single attending physician has a real-time dosimeter, so they can look up their dose at the end of every case and make improvements to change behavior. So I think that's an absolutely integral part of any radiation safety program. The second learning point here is traditionally we all have our favorite views to work in. I'm going to tell you that the cranial view is terrible. Okay, if you like radiation, work in the cranial view. If you don't like radiation, work in the ariocaudal view. Most LAD lesions can be treated very effectively in an ariocaudal view. And it drives me nuts when I see constantly people working in steep cranial projections, and you can see with real-time dosimetry that the meter is constantly in the red, and these people are getting absolutely fried. So if there's any one thing you do today, apart from getting a dosimeter, is to absolutely limit your use of cranial views. Most interventions can be performed in caudal views alone. Best view is the ariocaudal. The third point is watch the meter. Watch the meter during the case. So you're all familiar looking at the total Aerokerma dose on machines. As soon as you put your foot on the pedal, that changes to the milligrams per minute. That's how quickly you're burning through the gas tank. 34 milligrams per minute. you're going to go through stuff slowly, but if you're in a steep angle and you're burning 80 or 90 milligrays of radiation a minute, you're going to start to get up some pretty high radiation doses very quickly. Secondly, magnification has a big impact. Every time you magnify up, you increase the amount of the intensity of the X-rays to get through that small aperture. You increase the scatter radiation dose. So try to work on a low magnification, but don't forget collimation. So learning point number 4, we're all traditionally taught about table height, probably during our fellowship orientation. And so which of these positions here do you think has least scatter radiation to the operator? The high, the mid, or the low table height? Ziad, I'm going to pick on you.
Low. I'm going to say low.
Low, okay. Well, that's a little converse to traditional teaching where we're all taught to keep the table high, and let me show you why. It's actually, you're right, the lower the better. And the reason is that the patient, particularly the patient's back, is the source of radiation. They're the source. It's not the bottom of the C-arm. So we did an experiment here with one of my fellows who wore 4 real-time dosimeters at those various heights. So the fellow 5'10", and you can see these badges are 6 inches apart. So the second badge down there basically simulates the position of a thyroid in an operator who's 5'4". And you can see that over 50 patients, the median dose at this badge is 2.4 milligrams, whereas this badge is 1.1. So a matter of 6 inches distance from the table height can half or double the radiation dose. And I think this has important implications for operators who are less tall. It's an important point. So try to keep the table lower if possible at a comfortable working height, but avoid raising the table too high. Last learning point is there are many different shielding systems available on the market. We've had experience with the Protego, but it doesn't matter what you use, just get some additional shielding. We routinely use the RadPad. This is one of the devices, inexpensive, well-studied, in one randomized trial that shows about a 20% reduction in the radiation dose to the operator. So I don't care what you use, but just use something other than the standard systems that come with your X-ray cath lab system. And so the positioning of the RadPad is important, and I think that's one of the things we've learned with the real-time dosimetry, is you really want to position this carefully over the femoral and the pelvis, because some of the radiation does reflect off the inside of the pelvis towards the operator. So these are the 5 learning points. Use real-time dosimetry, avoid cranial projections like the plague, use lower magnification when possible, and make sure you use the collimation. Avoid raising the table too high, and maximize your shielding. Anything is better than nothing. Thank you very much.
Great. Thank you, Simon. That was terrific. Maybe we'll get some of the panelists involved and maybe ask what techniques they're using, whether they do real-time monitoring, and also whether they have used Rampart or any of those.
Thank you. So we do use the shielding techniques, the Rampart in at my previous institution, especially for long cases like BPAs. We find that that's really helpful for the operators.
I use a human shield. I have a fellow that I position right between the patient and myself. It's proven to be very effective.
Also good for bullets.
So we use the RadPads, as Dr. Dixon mentioned, across the thigh and the hip area, but also we emphasize in the practice to have a real-time radiation dose. So especially for the fellows who's there every day, we're trying to negotiate with the administration to get a real time for each attending, at least who's doing multiple cases a week. And the last thing is the practice of the lowering the table and then collimation. Especially we do a lot of peripheral in our lab, and collimation is helpful.
And to add to that point about the shielding, you very accurately said it. It's important to know where you place your RadPad, or even if you use the Rampart, to make sure that it's properly positioned, because having a shielding device but not putting it in the right place or making sure it's well utilized, it makes it of no effect.
Can you talk about how collimation helps with reducing the scatter?
sorry, the question was how it reduces.
Collimation.
Collimation.
So collimation will the intensity of the X-rays going through the patient when you're on lower magnification is less. So the higher intensity, the more likely to reflect off body structures. So collimating reduces dose area product, which reduces patient dose, but also reduces the scatter dose.
So let me put you on the spot, right? I actually had my capital budget meeting like last week, and I said I want one of these new fancy X-ray systems, X-ray blockers. How do I decide? Are they all the same? Like, should I save a bunch of money and get a rad pad, or should I, spend $150,000 buy a Rampart?
So complex questions, right? And it depends on how much you've got in the budget. I have no question that there's huge differences in the different X-ray systems, and particularly aging systems. If you've got cath labs in your system that are older than 7 or 8 years, they probably shouldn't be there. We do. We have 15-year-old cath labs, but I know that those old cath labs spit out a whole lot more radiation than the newer generation technology. So, and that's a dirty secret in the field that people don't want to talk about. And administrators don't want to talk about it because it's $1 million or more for every new cath lab system. Tough, shielding, Rampart, real-time dosimetry, new cath lab, a lot of tough, questions there. I think if operators are knocking on my door asking for additional equipment to protect themselves, I got to provide it. As a leader and administrator, if the technology is available to provide additional protection over and above what is available in the standardized systems, and I don't provide it and they have a bad outcome, it's going to be terrible. I had one of my trainees call me a few weeks ago who's extremely well trained, the trainee, and has been in practice now for about 6 years, maybe longer, and has decided to back out of the cath lab and stop doing interventions because the attending now has posterior cataracts. So not even age 50. And this is in the modern era, 2023. So despite the improvements in the technology, we're still getting a ton of radiation. We got a ton more back 20, 30 years ago, but we're still getting enough that's affecting our trainees, affecting our careers. And I think that's heartbreaking. So we have to, as a community, do a much better job at protecting our trainees, protecting ourselves, raising awareness.
Simon, that was great. An not unrelated issue is orthopedic injuries from lead. And we recently looked at the Rampart, and what's being sold as actually is leadless operation. I wonder about your thoughts on that.
So I know there have been many live case demonstrations of Rampart with operators not wearing lead, and I got to be honest with you, that makes me a little nervous. We evaluated the Protego system in preclinical testing, and that reduced the radiation exposure about 98%. The state of Michigan signed off and allowed physicians, and we have several physicians in our lab who routinely do not wear lead with the Protego system, but they have a real-time dosimeter because you just need a little crack in the system where you don't have the pads in the right place and you can get exposed. So you've got to monitor it really, really closely. Rampart, to my knowledge, and I've asked for data, I haven't seen any data to know the comparative efficacy of that to give me the comfort to go leadless.
So Simon, whether you buy the Rampart or the Protego, what you're saying is you should always wear the live dosimeter if you don't wear lead, especially so that you know if the protection is suboptimal. Is that right?
Absolutely.
And maybe one question. So we've seen many films during the meeting, and there's one hand or there's two hands, not of the patient, the operator in the field, under cine or fluoro. So what are your thoughts about that?
Drives me nuts. I mean, experienced interventionists putting their hands in the primary beam. I mean, that's primary radiation, not just scatter radiation. But that suggests a laxity with radiation safety. It really concerns me.
And then maybe one more question. So I guess the question that Ziad brought over, it wasn't answered. So if you can buy Rampart or Protego or zero gravity, as you said, there's no comparative studies, but you've worked more with one. I mean, what would you go at this point in 2023? Which do you think might provide the better protection?
It's a tough question. I think which device is going to get used more frequently, and that's going to be a little bit operator specific, whether you're more comfortable working in a zero gravity system or working behind the Protego shield. So I think there are many factors that play into that question, Manos. I think it's a little tough to ask in the absence of comparative studies. I mean, I can say that the zero gravity and the Protego clearly provide very significant protection of radiation. I haven't seen data of Protego to be able to comment on that, so I tend to favor one of those two technologies.
So do you think, I mean, the intuitive thing here is that the X-ray companies bundle this into their package, right? You buy a new Siemens cath lab, it's 1.8 million, now it's 1.95 million, and it just comes with the radiation protection. Do you think that is what is going to happen or what should happen?
Well, that's already happening with the dosimetry, fortunately. So when you buy a new cath lab now, you'll usually get it with a real-time dosimetry system, but the question is where you're going to bundle it in with additional shielding. And again, that may happen. We hoped that was going to happen with another technology called ControlRad, right, with the Siemens system, but unfortunately that company didn't survive the trials and tribulations of VC funding. But I think we may get to that point.
Just have one last comment about we talked about the patients, physicians, but also what we noticed, our staff radiation dose has been extremely high. The nurses and techs, especially the nurse kind of administering medication. During emergency, CPR and stuff, I understand sometimes they have to be close, but in elective cases, we noticed that we didn't randomize. We did an IV that runs all the way to the feet of the patient, compared the standard what we have been doing, and we cut the dose for the nurses staff by half by just running that tubing. Just a practice that would minimize the radiation.
Yeah, thank you.
And
Thank you for
remember
mentioning that.
I was just going to say, remember the staff does like 12 or 15 cases. So they're doing that all day and every day while we do our case and then go to clinic or do other things. So their exposure is actually cumulatively very high.
Yeah, I thank you for bringing that up, and I totally agree with that comment. With the real-time dosimeter, we found that a nurse approaching the head of the patient to give additional heparin or sedation or whatever may get more dose in that very small encounter if you're on fluoroscopy than you may get during the whole case. Okay?
Yeah.
So that very limited exposure while the beam is on, going close to the head of the patient, the nurse or tech may get more radiation than we get through the entire case. So really imperative that we are cautious, protect our staff, and that goes for industry people as well. I see all the time in structural cases, the industry person, standing 4 feet away, 5 feet away from the CR, I'm getting absolutely blasted, having absolutely no idea about the effects of radiation. Drives me absolutely crazy.
Yeah, I was going to bring that up to the imaging and anesthesia in our structural cases. We really need to work on protecting them better as well. Last comment?
Especially with respect to the staff, one point just want to add is that we are very conscientious of our staff getting in when they administer heparin or any kind of sedation. We really stop flooring anything, of course, if you're not in an emergency situation. So for us as interventional, I think it's very important that if you see any nurses or techs coming in administering heparin, just stop the fluoro for a while. A few seconds would not change anything in the course of the case.
Totally agree. We've asked our staff to say, I need to approach the head of the patient, and that's telling us we need to come off fluoro, so they can do that. Question over here.
I'm just a nurse, so I appreciate that column, Saul. Regarding safety, this is a huge talk, so it means a lot to me because we are always at the head of the bed and getting hit. Regarding radiation safety shields, if you do go with the hanging lead, it does come with free swear words from the staff because we hate dressing it, but it does seem to work quite well. No, we just had this talk at work that all of our, radiation skirts that are mobile, the shields, they're cracked, they're falling apart. So that actually just came up as a capital budget of replacing that. So this talk is quite timely.
made it mandatory. If the fellow floor or the nurse or the tech, they bought them coffee.
All right, well, thank you very much, Simon. That was terrific.